To this fifth webinar of a series of sessions that have been taking place through the Latin American and Caribbean Network to strengthen health services through the Pan American Health Organization, also known as Reclassification. This work is part of a framework that was developed by a working group whose intention is to disseminate the deliberate search of reclassification of maternal mortality or maternal deaths. The first, we have the BIRMM methodology, which was a general outlook of what it is about. Second, we're going to talk about the Mexican experience. Third, we're going to talk the Argentine experience with a specific experience from Argentina. And the fourth one, which took place last Tuesday, was experience that Paraguay had in investigating and implemented this research. And now we're going to hear from our colleagues from the Dominican Republic, who will share their experience on implementing this deliberate search and reclassification of maternal deaths in their country. We will hear from Dr. Edna María Bargalló. I'm going to introduce her very briefly. We will have three presenters. The first one is Dr. María Nadal, who is a wellness doctor with a master's degree in public administration. She focuses on occupational health and specializes on modern health management and sexual and reproductive health management projects. She has a lot of experience in monitoring and assessment gender and reproductive health in women and adolescents. She also focuses on HIV/AIDS issues. She also has experience in project management, institutional quality, organizational development, maternal mortality, and epidemiology. In addition to that, she's very well versed in health policy and models in her country. We will also hear from Dr. María Emiliana Peña Sepúlveda, who's a doctor in medicine with a master's degree in public health, in epidemiology, and a postgrad degree in virtual learning environments. And currently she's a general director for general health situation analysis, monitoring assessment at the Ministry of Public Health in the Dominican Republic. And our third presenter will be Dr. Acerina Esmeralda Gilbert, who is a doctor in medicine with a master's degree in hospital management. She also has a degree in field epidemiology. She's also a professor at the field epidemiology program at the university. She is currently an epidemiology analyst at the Epidemiological Surveillance Department as part of the Public Health Ministry of her country. So these will be the three presenters that we will hear from today, and I would also like to go over some very basic and important elements that we need to bear in mind to be part of this webinar. First, we would like to kindly request you to please not turn on your microphone because of the way our presentations would work, because it could interfere with or disrupt our presenters. If you have any questions, each presentation would be 60 minutes maximum, and then we will open the floor for questions and answers that you can ask if you open the comment chat. You can ask your questions in writing there, and those questions will be related to what our presenters will be talking about. I will be reading the questions. We will pick from the list that appears on the screen, and they will be replied in real time during this 30-minute period. I would kindly ask you that if you have a question to please write to all in the options when you open your chat. It actually says to everyone, because that way everybody will be able to read your question. And if 30 minutes is not enough to answer the questions, please rest assured that your questions will be addressed at some point via email, in addition to summarizing all of the webinars that we mentioned, because this is the last one, this is the fifth one. So we will put a report on the Relaxes page where we'll include all the questions as well as the detailed report of this activity. So not only on the Relaxes website, but also in all of its social media and www.paho.org/relaxes. For this session, we will have simultaneous interpretation services into English. So in your invitation page, you had two options to either log on via Spanish original or English in the interpreted version. So without further ado, I would like to give the floor to our presenters. So we will hear from our doctors. Go ahead, please. Unfortunately, the sound quality is very poor. The interpreters will do their best. We have been working with technical support from Relaxes. The speaker is asking whether we can hear. The sound quality is very poor. I don't know if she can come closer to the mic. Well, like you've heard, could you please move on to the next slide? We will talk about the death registry, implementation of BIRMM, the main outcomes and limitations, the ongoing integration with epidemiological surveillance, and the contribution or cooperation we have received from PAHO. So let's begin with the issue of the registry for maternal deaths. We, as many other Latin American countries, have not been able to achieve the reduction goal set by 2015, and we're one of the countries with high maternal mortality. And that is why we need to develop better data, to develop the policies and plans that are necessary to achieve that reduction. Next slide, please. We can see that just like the majority of the countries, the issue of maternal registry doesn't have a certification coverage. We changed our civil registry legislation so oftentimes people do not have the necessary education to understand. However, by law, they need to be certified. That has changed over time. More and more, we do have medical certification, but we have access limitations to the registry in densely populated urban areas as well as in rural areas and municipalities where we don't have offices. So this registry is put together in a very inconsistent way. It can take anywhere from 3 months all the way up to a year, and this results in a high cost for the private citizen. There's also a disconnect with the main sources of information. We have several alternate mortality registries, and so we need to compile all of this information so that we don't miss out on any events. And on the other hand, just like with any other Latin American countries, we have issues with the wrong reclassification of causes of death. Maternal deaths are not reported accurately by cause, and we have mistakes in our registry. because there's a question. One of the questions is, if a young woman died, whether it happened during pregnancy, delivery, or a year after delivery. However, as we can see later on, we have great limitations because of wrongly reported information. And on the other hand, there are errors in coding as far as selecting basic causes. Up until 2013, our country had centralized coding of all death certificates that were sent from all over the country. And so starting in 2013 and 14, we started expanding training opportunities, and we set coders at the subnational level, and therefore we also developed an online option to populate the death certificate. So we have been able to correct some errors in terms of coding and cost selection, but we still have a ways to go. Next, please. As we can see here, on the left side, we have the percentage of omissions in the question that has to do with the death certificate, and we can see that only in 2013, the majority of the people omitted this question regarding certification of death during women's fertile years. In our case, the fertile year question refers to the age group between 10 and 45 years old. What happened in 2013 is that we started decentralizing the typing of the certificates and started switching to coding. And for the deaths that occurred in that year, we started doing the deliberate search and reclassification of maternal deaths. That is to say, when certificates were digitized, we had already corrected that error, and that's why we have 48% omission rate for that year. Now, since now we digitalize it from the provincial level, we do the search first, then we reclassify the information, and only then do we report it. That's why we see that over the last few years there's been an increase, but the problem is that we hadn't corrected for the error in the deliberate search. Although we do have underreporting issues, we cannot deny that we have improved the certificate in general from 49 to 50%, which were the figures back in 2010. By 2016, the coverage of our registry was around 64%, which means that there's been a 14.3% improvement between 2010 and 2016, and hopefully with the database integration initiatives and the work we're doing at the Civil Registry Office, we can achieve an even greater increase. Now, as far as maternal mortality, starting in 1998 with a ruling from our lower house, it has become mandatory to report a death as a result of pregnancy, delivery, or postpartum between the ages of 10 and 49. However, we have seen that even though the surveillance system identifies around 170 cases, like you can see in the chart, in the population, we achieve anywhere from 30 to 40% of deaths that have that certificate. And since we started with the BIRMM process, the gain in terms of the quality of data that we had before was started being corrected, and the surveillance system starting to see progress in this regard as well. The important thing as far as the mortality registry goes is that more and more we need to monitor the population to see why these deaths are occurring. Because if we stick to surveillance, we're only going to identify the people that died as a result of that cause. But we are going to be leaving out a lot of women between the ages of 10 and 49 that might be having the same issues. Now, to talk about implementation, Dr. Edna will be addressing you. So I'll give the floor to her. Good morning, Edna Nadal. The objective is to reclassify deaths for women that died during fertile years. She needs to slow down because there's a lot of echo, and so it's very hard to hear her. So in 2014, we started reviewing the deaths from the previous year, 2013. And this was based mainly on identifying the deaths that may have been overlooked in the maternal mortality surveillance system. So, the Department of Health Information took care of this, and right now we have also included DASIS, which is a directorate that was created in 2015. Next one, please. So the process works like this. First, we need to certify the death, either at the health service level or at the house or the street, whatever the death occurs, then it's certified following the procedures set forth for certification. So we get the certification of maternal death, and then that maternal death notification is sent to CINAVE, which is our National Epidemiological Surveillance Health System, and later on, and then unrecorded deaths, so the ones that have not been classified as maternal deaths and which occur among women ages 10 to 49, follow a procedure which has to do with reviewing question 14 to see whether the box that says whether that person was pregnant or not, whether that box is checked or not. Now, if there's a question as to whether or not it was a maternal death, more investigation takes place, whether by reviewing the clinical files. Next slide, please. Or whether the person died at a health center, and a determination is made if the woman died in the community or in her house, an autopsy must be performed. The objective of this further investigation is to determine whether the female patient, when she died, was pregnant, had just delivered a baby, or it was within a year of having delivered a baby. So the deaths that are classified as maternal in nature are added to the CINAVE system, and it is considered a death that had not been reflected in the epidemiological surveillance system. So phase A has to do with identifying the death certificate showing the woman was between the ages of 10 and 49 years old. And this is a procedure that must take place on a routine basis at the local level. This is up to the statistician to do, or the person that's in charge of managing the information system. So once we have identified the female deaths between the ages of 10 and 49, we match that to the SYNAVID database to see whether that death has already been classified as a maternal death, and whether that shows on the death certificate. So we try to match the information to make sure that they both reflect the same cause of death. So if there is a match and they are considered confirmed maternal deaths, we send a copy of the certificate together with investigation documentation to DASIS, which is our information department, so they can compile all the evidence for the case. And the certificate has to be amended to reflect maternal death. And if there is no match, then we go back to question 14, like I said before, to see whether or not the box that asked whether the person was pregnant or had just delivered a baby was checked or not. And then we also check question 22, which has to do with violent cause of death. And we discard all violent deaths with the exception of suicide by hanging or shooting. No, not shooting, because all this could be a suicide as a result of taking illegal substances. That's discarded because the woman may have been seeking an abortion and they overdid it with the drugs and died. We also analyze the basic cause of death and compare it to the list with causes of death, which compiles 52 causes of death, and if one of those causes are considered basic causes, it needs to be investigated. And like I said, if a death took place at a health center, then we need to review the medical file, and if the person died in the community or at her house, then an autopsy must take place. Next one, please. So the deaths that do not require investigation are considered as related with injuries or injury-related. And in question 14, 5 must be checked, or item 5 must be checked. That is to say that that person was not pregnant during the 11 months previous to her death, and 9 is overlooked. But if item 5 indicates that the person was not pregnant, but one of the Ramos list causes is listed, then it must be further investigated. So we need to make sure we find out the cause. Let's move on to the next one. Okay, so as far as classification, after we go over the death certificates, we can say highly probable maternal and suspected maternal. The highly probable maternal cause of death means all deaths where items 1, 2, 3, or 4 in question 14 are checked, or all deaths whose causes are diagnosed as occurring due to maternal complications. Suspected maternal are all of the ones whose causes of death match the causes in the Ramos list, and we also have to see whether item 22 is checked, because it could be an accident due to anesthesia. 6 is non-violent, 9 is overlooked, and we have to see the causes are included in the Ramos list. And if items 5 has been checked, suicide, in question 22 as a result of intake of substance, we need to investigate to see whether there was an attempted abortion. So now we move on to phase B to investigate death identified as probable or suspected. First, we need to look at the clinical file. If the person died at a health center, if she died in the community, then it needs to be investigated, and as a result of these investigations, we need to either ratify or modify the cause of death, and then this is complemented with other causes or other sources. So we need to see in what database that death is logged into, whether it's a general death or maternal-related death.
Vamos a pasar entonces a hablar de los principales resultados. La primera medición que hizo en el 2013.
So the first measurement is 1,1918 for women between the ages of 10 and 49, or about 508 cases were found that did not apply for the study, either because the codes of basic cause of death were not amongst the 52 codes in the list, which are the criteria that would apply for this. And also, they did not meet the code under the list from under pregnancy and delivery, and it did not include the 34 code. Well, they did apply for the study 1,410, out of which through investigation, 880 cases were discarded, and 314 were not investigated, either because there were no files, no record found, so those cases were not investigated. As a result, that obtained from the study, there were 217 confirmed maternal deaths, out of which, and excluding those under code 96 or 97, which came in late, there were 13 of those, and those that were documented living outside of the country, we had a total, for the total calculation of 2,002 maternal deaths for the year. Moving on here, for 2016, because for 2017, the investigation process has not been completed yet. So for that year, we have recorded in the database with the death certificate 2,625, out of which 34% qualified for investigation based on the definition of suspected cases, and also probable maternal deaths, and also the number of cases that did not apply to be investigated was 1,733. The ones that were investigated, out of those, 190 were found total maternal deaths, and then 401 were recorded as non-maternal maternal deaths based on the investigation, and about 301 where the investigation was not completed for those. Now, in relation to for maternal death, we had a total of 178 RMN considered as late death. We had 11 maternal deaths for this year, and for the cases of those residing abroad, we had 1 case. in relation to the main gains or benefits that we have obtained from the deliberate search and the reclassification of maternal death based on the collection of data in the country, we have seen that during the last 4 years, in relation to the death registry, there have been an increase of 87, 82, 92, and 71% correspondingly. In the case for the surveillance, there was a 70% increase for 2013. And as you can see, there has been a constant improvement. Then also having another decrease in the fact that because of the fact that since this is a procedure that is done locally, many times what happens is that people come in and they say, we already reported this to the main system, but then what you need to require documentation to be able to back this up. You need a death certificate in order to record this in the general database for deaths in the country. So ideally, the drop in or the figures that we have reflects all the deaths throughout the country, but also this data collection has also contributed to the improvement of information. We had many deaths of unknown causes, and so in many cases there was necropsies performed, but there was no notification of that. But now, since this is being incorporated into the database of the country, so now we know that some cases that had not been reported before, because the only data that was available was that the woman was pregnant, and then it came in as a late date because later the woman was found to have died from other causes, either accident. So there has been an improvement in the quality of the data in the registry. Among the challenges, there is no doubt that we need to continue to improve the performance of investigations so we can reach the target that we have set for the country, which is to investigate 100% of deaths. Also to be able to develop linkages and integration with other sources. And even though we have already automated databases at the different Institute of Forensic Medicine, we are still pending having an agreement with the civil authorities in order that jointly with the statistical service we'll be able to record and to have a single integrated mortality rate database. Also, we need to automate the identification and the recording of the deliberate searches of the deaths, because all that compiling of that information is done manually, even though we would like to have improvements here, and so we need to see how we can link this to the general mortality database so we can update everything, upgrade it. Also, we need to continue to improve the vital statistic systems by coding the different causes of deaths and the basic causes of death, and in addition to develop a strategy to disseminate results of the investigation. So far, we have made some improvements in implementation, and we have already even budgeted this as part of our regular activities. However, publications is something that has not been completed, so those results have not been disseminated yet, so that's still something that is still pending. Yes, good morning. In relation to the ongoing integration with the epidemiological surveillance, currently with the regular matching of the databases at the CENAVI, that's what we do that on a regular basis. So what we do is comparing and matching the different sources to confirm the different cases, what are you are supposed to be under surveillance, and we compare it with the data recorded. Something else that we are doing through epidemiological surveillance is an exchange of skills on the different levels of procedures that we have, which are disaggregated. So, and also, in order to be able to do investigation and to apply the BIRMM methodology, something else that we're doing is that we are incorporating a procedure to evaluate system performance. Okay, now here we should point out that so far during this 4 years that we have been implementing the system, we have been able to do this thanks to all the technical and financial support provided by PAHO. And since in 2015, we had an experience through the Zero Death project that took place at the health centers. So thanks to this program, we were able to improve, and this is a first line and second line of action. This has been a joint work done by the statistical and epidemiological department, and also the youth and adolescent health program, with different interventions that are comprehensive in nature in order to improve the performance in Region 7, which was a region that had one of the highest mortality rates. And so this is where we are sharing the best results now. And also, obviously, we have gotten a lot of support through Relaxis and CNC of Mexico, and also not only with them, but also at the local and national level, we have been had the support of many technicians. In fact, we had the first workshop and the first deliberate search for maternal deaths. It should be pointed out here that the Ramos list, or the Ramos code, which is our 52 codes, we have this code here for this year. We only have those codes, but we have enlarged it to 52 because we have added silent deaths, also unassisted and mated death, or unknown causes of death, because we were able to observe that because of a management problem, hospitals reported the death, and they waited like 48 hours to report, and many times the report was not filled out at the time of death. So that meant that when it came to notification or to issuing the certificate, they did not report the cause of death. So we had many cases of those cases of women whose reports were not completely filled. But now we have the code, so we can complete the list. We are not showing it here, but whoever is interested in looking at those lists, we can send it to you. And we can show you this at the different levels, including the local level, the provincial level, where we are able to identify what we are able to do when we deal with a case from death from an unknown case. And also, under the Ramos study, this has helped us to focus our efforts to uncover concealed cases for different causes of death, to uncover different causes of death. So with this, we have completed the presentation, and we can move on to the questions now. Very well, thank you very much, doctors, for the excellent presentations. So we are going to read the questions. I'm going to be reading them in the order that they came in. We have a first question from María from Costa Rica. It says, good morning. Thank you very much for the presentation. About the measurement of coverage, do you use your own methodology or do you use the UN methodology? Yes, greetings to Olga. In reality, we have made the estimate of the National Statistical Office, which has an estimate of deaths or mortality rate for the country as a whole. But besides that, we have estimated the coverage that is not only found in the civil registry, but also in the overall mortality rate. Thank you. There is another question from Victor Gonzalez from Venezuela. So if you could, the question is, I would like to know about the measuring coverage, and I think that would have been answered by the last response that we heard. Also, do you measure that in the country in the year when you had to process, or also extemporaneous maternal deaths? Or regarding other sources of statistical instruments through comparative studies of coverage, considering the different sources? I would like to clarify that the data for coverage that I presented at the beginning is not in relation to maternal deaths. It's in relation to deaths in general that take place in the country. We see that in one way or another, we see that if the country is not having good coverage of death registries, then that will have an impact on the data that we collect for this group. Now, comparing the civil registry with the medical certificates, which is what we use to compare, we find that we have about 80% estimate of that coverage. And also we're able to capture for older women, we find that there are more deaths among that age group in older women. We see also that we have recorded a highest number of deaths in women than in men. And also because of the different administrative problems that we're having internally, and because of the way that the pathology centers work in the country, we only have 4 of them. So there's a problem with those sources of data. So when filing those certificate, you are supposed to record the source of that data. But sometimes when somebody's living outside from those centers, then you lose that reporting, or you don't have the reporting of that information, and doesn't reach the main department. The other thing is that the other increase in the rate was due to the level of calculated estimated deaths. So perhaps, I don't know whether I was able to answer your question or not. Yes. Well, in case that you still want to add something else, you can still add another comment or additional question. There's another question. What code criteria do you use for the disease classification code? What do you use to classify suspected cases? Not only, also, what other criteria are applied? Or the question is whether, in addition to the codes that you mentioned in the presentation, whether you have another criteria for suspected cases. Yes, in addition to the cases that we have for 10 cases for classification, for complications of maternal deaths, and aggravated cases, by adding the 3 other ones that we mentioned, we also have another criterion, which is that regardless of the cause that has been reported, if question number 4 says that the woman dies during pregnancy or after pregnancy, that would lead to an investigation in order to confirm whether it was considered a maternal death. For instance, the last case that was reported to us, it was a basic cause that was reported, but it was under question 14. The answer that was given is that the woman died during pregnancy. When we could investigate, we were able to confirm that there was an error in filling out the information. So this made it possible to corroborate whether it had been, in fact, a maternal death or not. So as I said, we have the Ramos codes and the other codes we mentioned, but also the question that where we ask whether the death took place during pregnancy, delivery, or puerperium. And then after the investigation, then this is further investigated to see what are the probable causes of maternal deaths. Thank you very much. Now we have another question from Juan Siquén. The question is, what is the role of the Department of Maternal Health, of the Ministry of Health, in the process, in the analysis process and in the determination of maternal death? I did not go further into the procedures of the surveillance method. According to this, once there is a maternal death, the maternal death has to be investigated or analyzed by an expert committee, either at the hospital or at the different ministry or health departments. And then this would require that the committees would have to monitor those cases. And in this case, the Department for Maternal and Children Health, they will be involved in the investigation. So whenever we deal with some of these cases and we meet together to have a discussion to consider the case, as we had a case last year of a death which first was reported as an ectopic pregnancy, but then later on when the file was sent to us and we confirmed the information, we were able to see that at the time of death, the woman was 4 weeks pregnant, and also there was a brain tumor, and there were some other related causes. So at the time when the death was recorded, the only thing that was recorded was that the carcinoma. We all know either it's a tumor or a brain tumor. It is also a maternal death. So in that case, it is sent to the committee of experts, and they have to make a decision as to what the cause of the results will be. But of course, this is all pending and subject to the results of the biopsy. And that is done by the Health Division. Yes, thank you very much, Doctor. There is another question which says, what factors explain other causes of maternal deaths that are unexplained? Well, there are some cases that are not investigated. What's the reason why some cases are not investigated? Well, there are different factors that would explain that. One of them is that whenever we start the investigation, we also write down the place of occurrence. But as it happens in many of our countries, the person could be applying or filing information in one state or locality, but they live in another one. So when we find that the report does not meet the criteria, or they don't meet the requirements, or they don't have all that information, location, and all the information that would allow us to confirm the time of death, so we forward that case to the place of residence. So many times the person goes back to the place of residence, they will not, or we're not able to find any relative to confirm that information, and thus the investigation is not completed. Another process that takes place is that the level of deaths that has to be investigated is very high. Many times they're all concentrated in only one of the areas of health, in the health departments. This year, thanks to, and with the support of the ministry, we are helping the local health departments through different investigators so they'll be able to complete all of this process. But the experience that I've seen in many countries and in Mexico is that for the first few years, usually many more deaths go without an investigation. So the investigation either comes in late, or the report comes in late, or many times whenever we send the list of maternal deaths to the different local level, then this cannot be investigated or compared with the local local data. Sometimes there is a delay, and maybe like a year later, the investigation will be continued. So we're trying to integrate all of these indicators or performance indicators, where we are also applying those at the local level, and also applying the surveillance system so that we can increasingly complete the investigations and the reporting. Also, perhaps this is happening too fast, or the investigations are coming in too quickly. And furthermore, there is also shortage of staff, and there is not enough staff because they're busy investigating other cases, such as other diseases such as dengue or others, so they're busy with other things. So we need to strengthen and empower the local teams with more personnel so they can meet all these new requirements. Very well, thank you very much. The next question is, why don't you include deaths of people living abroad for the causes of maternal death? Do you do that for all the cases of people living abroad? No. When we determine somebody living outside of the country, we don't consider that. It means so we'll have a very few cases. We only have 4 of those cases. It can be the case of a person or a tourist who was visiting the country, and then they went into labor, and maybe they died while they were in the country. So that is not considered as a national case. To consider residence, somebody as a resident in the country, you have to be in the country for more than 3 years. So in many cases, people come across the border, and they're here temporarily, but they're coming from another country. And this is how we confirm those cases. This is a criterion that we have decided. It's not something that we have decided. It's something that it has been established by WHO in order to make that establish a difference between the death rates in a country, in the national cases or the cases abroad. This is what we use the same criterion for neonatal deaths. So also for almost most of the epidemiological events, we also use the same criterion to know whether the event took place in the country or abroad. Very well, thank you. Yes, something else which is very important to add. One thing is that the numerator is not recorded for the reason, but when we put in the number of cases or the deaths occurred, there is a total number. There is a report that is available on the overall situation in the country, which we can share with you, where it can show by place of death, by place and time of death, and it shows all the different cases. And also, out of the numerator, we take the number of deaths for the calculation, but it's important to analyze that. In fact, for the country, the number is continuously increasing, and that is significant. And that is one of the reasons why, even though they don't die within the 42 days after delivery, but afterwards, and that will lead. And that would lead to other problems. Very well, thank you very much. There's another question from our colleague Victor from Venezuela. In order to contribute the BIRMM percentage, how do you estimate the weight of the contribution of each method? Well, we did not mention this here. What we wanted to point out instead is that if we did not apply the BIRMM, the mortality death rate will be about 35 or 40 cases. So we wanted to see separately what the contribution was, because we know that the surveillance system has a very high contribution to that figure. However, even though what we found from other sources, either through the death certificate or through Pathology Institute, it is important to point out here that the surveillance system has factual reporting at the different establishments. And according to the last household survey, we had almost about 91%. This means that the number of events taking place at a health center is recorded in that way. But also, what we are reporting is only what takes place in the homes where the women did not go to a health center. If we want to see the different inequities and compare, then we need to compare the different sources and the different information, and also go to compare it with the same location that we're looking at. Very well, thank you. The next question is from Miguel Angel, and it says, do you identify the factors that explain the difference between to explain the fact that in 2011 there were almost 80% of cases of deaths of women in childbearing ages were investigated, and then in other years only a lower percentage? Well, we will have to take a look following the list, and because of the use of that list, there have been improvements, at least for the last year. The reporting of whether the woman died during pregnancy, delivery, or puerperium. And then we also have to confine this and limit it to the cause of death. There are increasingly a greater number of violent deaths caused by accidents, so it is very likely that that's the reason why we have a lower level or number of deaths that are investigated.
In our next report, we're going to try to break down the causes that were investigated and those that were not investigated, so we can include that as part of our analysis. Very well then. Next question is from Olga from Costa Rica, and it says, with BIRMM, did you find a hidden maternal death, and did you correct for the errors in your country database? Well, we used to use a correction factor. We had performed a study that back in '99 was part of our Ramos list, and we sent a registry for SINAVE, including 44% of the cases. Based on that, we made the adjustments to come up with the expected number of deaths. But where we started implemented BIRMM, and with this search effort, we decided to rather publish the information that we got with our deliberate search. And this is an ongoing discussion that we have, because we believe that if with BIRMM we have a 17% gain as compared to our surveillance system, then I believe that we may be overestimating, maybe. But like I said, this is an internal ongoing discussion, and we're also in discussions with our National Statistics Department and the analysis unit from our Ministry of Economics to see how we go about this. Because we gave them the numerator as tight as possible, and hopefully they'll do their work to see whether they can come up with the right estimate. But I believe that unless we are able to investigate all of the deaths that weren't investigation, it will be impossible to come up with the exact estimate. But we need support from other units to do it properly. Very well, thank you. Our next question, rather than a question, I think this is a comment. I'm going to read a very good experience from the country. In spite of the low coverage for deaths, it is important to do this exercise with available information. One of the first slides was showing a horizontal bar graph that was showing information to 2013, and I don't know if that was an omission of the death cause or omission of information on women who had died between the ages of 10 and 49. Well, what happens is that on the one hand, I was referring to the question. We're trying to have that question be as tight as possible. And on the other hand, we have the coverage from 2010 to 2016, and that was for total, the registry with total deaths. The other chart was there just to show that if we didn't use BIRMM, our surveillance system would still make quite a high contribution, but the mortality rate in our country was not very accurate unless we do this deliberate death search. I don't know if this is what you were referring to with your graph comment. Okay, but anyways, if you agree, maybe you can expand on your question when you send your comments in writing after the webinar. There's a question from Victor Gonzalez in Venezuela, and it says, the scope of skill transfer at the levels to follow up on BIRMM, is that done on an ongoing program or through specific efforts based on technical support and funded received from PAHO, WHO, Relaxes, Semestres, or other cooperation agencies? It's a question. Ever since we started working on BIRMM, all of budgetable activities were considered part of our annual activities. In the different divisions that deal with this topic. But there's also an effort at the planning department level, which is where we have our health information system department, because they need to provide support in managing vital statistics for the ministry. Now, as far as BIRMM goes, every year we budget for oversight or supervision. For example, when we need to match information, if we have provinces that have 0 notified deaths or 0 maternal deaths on our death system, then a supervisor needs to pay a visit to that locality and do a physical review of their records to see whether it's actually true that no maternal deaths occur, or it was just the fact of not reporting them. So it could be a province with very low maternal death prevalence, but we had some other provinces that for 2 or 3 years in a row, they had not systematically submitted maternal death information in any of the system. But then when we went and did the on-site visit and checked their physical records for the previous year, there had been deaths, but they just had not been reported. So we budget for this, and we include the cost for all these on-site visits, and then every year we hold workshops, and this is with our own budget, by the way, from our ministry, to strengthen the concept of how this procedure works. Thank you. There's another question from Juana Sequen, and it says, are there any examples on the level of maternal death coverages that have been detected in the BIRMM system? And along the same lines, what kind of relationship is there with the private sector? Well, normally, just like we have around 30% private sector participation, from what we have seen with our surveillance system, the private sector abide by notification rules. And also when we do these institutional searches, we do a random sampling of the centers, and we go and do an on-site visit in order to check the records and see whether the deaths have been correctly reported. It is worth mentioning that our death certificate is issued in an original form and 2 copies. One of the copies has to be retained by the health center in order to have the necessary paper trail when the audit comes. The other copy is sent to the division health that center reports to, and the original copy is sent to the main office. But the occurrence of these events is between 70 and 80% in the public sector, and about 15 to 20% the private sector, and about 10% at the household level or along the way in transit. We also have military agencies that account for an additional 10%, but that's part of the public sector. And regarding our Social Security administration, there's a bill that was passed in 2015, and it says that there are certain sectors of the armed forces where they have to report to the National Health Service, and that includes all military hospitals. Thank you. Rosa Lopez wrote 2 questions. She said, that's what I wanted to ask. Who make up BIRMM? Thank you. And then she adds another question when you were talking about the issue of foreign deaths. They said, do you register foreign residents in your country because the data may be lost? Well, that's an ongoing issue. The nationality is written down, and we provide information of maternal deaths by nationality of the deceased woman. Nationality is one thing, though, country of origin, and another thing is habitual residence in a country. You cannot imagine how long we've discussed that, and we keep having that argument where it's how we report this. Habitual residence information is more important at the provincial level, but more and more, especially through the surveillance system and the certificate itself, we are including the address with street and number where the person resides, which enables us to locate the people for the purposes of autopsies that need to take place in the community, as well as interviews. Thank you. Next one. Okay, the next one comes from Virginia Hernandez, and it says, "Good morning. Congratulations on your presentation. I found kind of interesting to see that address with contribution to deaths by year, where total maternal deaths have been dropping from 2013 to 2016. Even if we're addressing the issue of underreporting, it could be interpreted as a considerable reduction in maternal months. What is the reason why maternal deaths were lower in that time period?" Well, when we look at a long-term trend in maternal deaths, it is important to measure the reasons. So maybe over the course of 4 years, it could be a downward trend. But then, for example, in 2017, we have 104.3. So it started creeping back up. One of the reasons is that in 2016, we did a deliberate search. I think it's very hard to hide the corpse of a pregnant woman in my country. Unlike what happens with children, there's a lot of underreporting, and it's kind of hard to hide the corpse. But anyways, in the case of deaths in 2016, that year we had a Zika epidemic. And one of the main campaigns that the Ministry of Health pursued was to postpone pregnancies. So we would have to see to what extent that public message contributed to a reduction in pregnancies. But in the main maternal centers, we saw that there had been a reduction in live births as compared to previous years. That year, also a hospital closed in order to build a health city, which has not opened yet, by the way. And so that could be another reason. And the maternal and child health program includes targeted interventions, and we also have other hospitals that are sponsored by UNICEF with all of the interventions that have to do with clean deliveries. In the case of Aswa, which was a community with high maternal deaths, there was a considerable reduction that year. Another maternal center in our metropolitan center also see a significant reduction in pregnancies compared to the number of deaths that they had in the past. And it could be as a result of these public messages. Unfortunately, one of the things that we were trying to attempt is for those interventions to be documented in order to later on compare the results and come up with an impact assessment to see whether there was true correlation between these events. However, last year there was a considerable increase, and it just happens to be the year where at the same time we started remodeling services, and the main maternal center in our country had not had an intensive care unit, and they were referring hospitals to their second or third tier hospitals. So it is quite striking that that happened to result in an increase. So they refer the patients to the second or third tier hospitals, but they may not have had the necessary resources to take care of critical patients. So this could also be a reason why we saw an increase last year. Currently, that increase that was seen last year, which went from 90 to 104, was taken by the government as a signal that a plan needed to be implemented to try to impact the problem, because as you know, maternal deaths causes a lot of problems. Thank you. Okay, the next question from Olga as well from Costa Rica. It says, the decision the country makes to not include the numerator for maternal deaths of people that do not reside in the country make the maternal death reason indicator not be comparable to the ones from other countries, where by definition all deaths occurred in a national territory, regardless of whether or not that person is a resident or not, are included in the calculation. So go ahead. Well, honestly, I believe that this is the year where we're seeing the highest normally. Normally we have like one death or two at the very most in that category, so it's not that significant. And once again, one thing is the calculation for the reason for maternal death, because as far as reasons go, we build them together based on the residency of the person that died, from the epidemiological point of view, not from the province where the death occurred. Because if we did that, in my country there would be only 2 provinces that would have the highest maternal rates, because that's where all the resources are concentrated. So the metropolitan area and the Cibao Norte regions, which is Santiago, those are the 2 regions that have the highest number of hospitals with highest resources, with an OBGYN department. So obviously people would migrate there. And so that's why we don't do it that way, because those 2 will be the only 2 regions in the country, or the ones that have the highest number. So we make an effort to account for the death in the area of residence. And then we see whether within the region there is a large sector of the population that needs to go to another region because the program has had issues in the past. It is also an issue of quality. So basically, oftentimes when the place where the delivery takes place is not the same place that followed up during the pregnancy. There's also a survey that was done with UFA and UMPA and our National Health Services, where one of the aspects that were highlighted was that even if there are protocols to take care of the main reasons that lead to obstetric and neonatal death, we are still having less than 40% of cases that follow the protocols. So there's an ongoing discussion on the issue of health. The most important thing has to do with the fact that our women get to the hospital, but the service is very fragmented. There's a lot of people or stages that the person has to go through, and this is something that does not happen in the private sector. So there is a higher guarantee that the whole delivery process will be addressed by a single decision maker. So in the areas that we're seeing improvement is the hospital in one of the provinces that saw a significant reduction. So now they have doulas that go with the pregnant women that follow up on their pregnancies. And oftentimes the person can deliver the baby at the hospital, but they have the same person that knows the person, so they can detect whenever issues occur. And so they are implementing this doula program, and this ensures a higher efficiency. The main cause of death continues to be complications during pregnancy. Hemorrhages has also a leading cause of death, but it's also high up there. And then we have sepsis as well. Okay, we only have 8 minutes left to conclude this session. And I'm going to read one more question. And then whatever questions or comments are not addressed later on, we'll include it in the report that will be posted on the Relax's website. So the question is from Jose Rodriguez, and it says, very good presentation. Are there any analysis performed on the reasons for maternal deaths by economic area, and whether it's by rural or urban areas? Okay, well, we're having a lot of issues with identifying the area. We have an area here. Some rural areas may be considered urban, even though they are not. The Ministry of Economics publishes the different guidelines that must be followed to classify an area as rural and urban based on, among other things, multidimensional poverty. And thanks to the WHO, we have developed a profile where we took information from the surveillance system on maternal deaths, as well as information on female illiteracy by area in the territory. And this breakdown enables us to see that the gaps between, or rather, the best indicator for female literacy and the ones that had the worst showed a significant gap. We also saw this with maternal and infant deaths. We also did a study on maternal death in the metropolitan area, and we were not able to use the live birth indicator, but rather the population information from our latest census, and even using that, we see a significant correlation between maternal health in areas that are considered high poverty versus the levels of the population that are not in that situation. And there's obviously a significant gap there. Okay, so we're going to read one final question. And apparently, at some point, there wasn't a lot of this question was not very clear. This question is from Olga, and she says, have you found hidden maternal deaths in your study? A question had been asked about this before. She was asking whether you had discovered hidden deaths in your studies. On maternal deaths, the answer is yes. Yes, every year we find deaths like this. That's why I was saying that sometimes we see deaths that happen within a household or among migrant sectors of the population, because we have a high migrant population from Haiti and those where autopsy is pending. The certificate says that there's no confirmation on pregnancy, but we're awaiting results from the autopsy to confirm whether or not it was maternal death. And when we take a look at the autopsy databases, we can see that there are deaths, for example, with ectopic pregnancies or abortions. Abortion is illegal in our country, by the way. So they are identified only when an autopsy is performed and the cause of death can be determined. In some cases, there is suspect poisoning, and then when the autopsy takes place, it turns out to be an ectopic pregnancy. So maybe the doctors did not think that there was a pregnancy involved. I'm sorry, they're all talking at once. Yes, in the case of an unreported death, there was a certificate that was sent to the province division, but nobody recorded it as an abortion death. Okay, well, thank you very much. Thank you to our presenters for sharing your very interesting experience. Thank you, Dr. Emilia, Edna, María, Nadal, and Dr. Esmeralda. And with this, we are going to conclude this session. But let me remind you that the responses that have not been provided during this live session will be made available on the Relaxis website. And I have just been told that there are some questions that could be expanded on, and that additional information will be included on the Relaxis website. And we will also upload all the available material from this webinar and all the previous ones. They will all be uploaded to the Relaxis website, as well as all of its social media accounts. And there will also be a summary of this experience on those same media outlets. So please let your colleagues know so they can subscribe to the Relaxis website, so that they can be notified about all the activities that will be taking place through Relaxis PAHO. Also, we will be uploading the videos both in English and in Spanish. They will be available on that website, and anybody can check those. Okay, without further ado, please continue to join us. Invite your colleagues to subscribe to the Relaxis website. And that's all we have. This is Janice, and we'll see you in our future sessions. Thank you.
Yo quería una pregunta que teníamos siempre de preguntar